Hello friends, I am Dr. Raka Sheohare, MD from Raipur, India. I'll be talking on incidental thyroid nodule. A nodule in the thyroid is a difficult and dubious diagnosis, and most of the patients are terrified. And I need to bust that myth and reality that every nodule is not a cancer. Incidental thyroid nodules are defined as nodules originally detected in a patients with no thyroid-related clinical symptoms, and they are accidentally found in examination or scans, and they are easily detected, but they are poorly characterized. ITNs are common and defined as discrete non-palpable lesions radiologically distinct from the surrounding parenchyma and are found on anatomic imaging. Prevalence of thyroid nodules identified by palpation is between 4% to 7%, but when we do imaging studies, then they are detected 10 times more nodules, which are most of the times benign. And women to men ratio is 4:1. They are more prevalent in females. How to evaluate and proceed? We all know that thyroid has a thyroxine hormone and it is modulated by TSH. So nodules, whether they are present, they can change the thyroxine thyroid physiology, and they can alter these hormones. So there are history, clinical science, lab scanning, prognosis, fate, and guidelines. How do we proceed? So complete history with emphasis on prior thyroid-related concerns, including medications, biopsies, radiations, original history, family history of thyroid disorders and syndromic patterns, symptoms like local symptoms like dysphagia, dysphonia, dyspnea, positional or nocturnal should alert the clinician to the possibility of compression or invasion. The physical examination, including thorough neck examination with lymph node examination, should be done. Management, the primary goal in managing ITN is to differentiate, which is very crucial, whether it's a malignant or benign, and that's the main concern regarding all of us. Most of our patients are terrified by these things only. So population-based studies have shown that risk of malignancy is 1.6% among patients with ITN, whereas studies of patients undergoing biopsy have estimated the risk of 12.8%. Here is the American College of Radiology recommendations where they found ITNs in CT or MRI, and if CT or MRI is suspicious, then we have to go for ultrasound imaging. And this, when the patient have limited life expectancy with enough of comorbidities, age very high, then we need not to probe too much to go for any fancy things. But in general population, when there is age is less than 35 and the nodule size is less than 1 centimeter, we need not to worry. But age is less than 35 with proper history, medical history, with history of thyroid disorders in family, we need to evaluate thyroid by ultrasound. And there again in general population, when age is more than 35 with 1.5 centimeter of size of nodule and less than 1.5 centimeter, we need to follow these kind of guidelines. So ultrasound features are very specific, and there are a lot of features. But I do not to go in minute details, but thyroid nodule features are microcalcification, hypoechogenicity, irregular margins, shaper taller than wider on transverse view, lymph node features like microcalcification, hyperechogenicity, peripheral vascularity, rounded shape, cystic aspect. These all are aspects which can show the signs of malignancy. Here the staging protocols by TNM, Bethesda, and thyroids, and we can know that normal thyroid ultrasound is called as thyroid 1 with benign aspects with simple cysts, spongiform nodules, white knight aspects. They are thyroids 2, and goes on increasing the thyroid staging when you have a high suspicious aspect taller than void shaped, irregular and microlobulated margins, microcalcifications, marked hypogenicity, and we have a thyroid 5, which is malignant type of thyroid nodule. So friends, to conclude in short nutshell, that incidental thyroid nodules represent a common problem encountered by surgeons and radiologists. Complete history and physical examination include thyroid function studies, dedicated thyroid ultrasound with a team of good endocrinologist physician, proper FNAC, cytological diagnosis, reassurance of the patient that these are not every time these are not malignant nodules. In case of any kind of indeterminate cytology where you're doubtful, then you need to go for repeat FNA biopsy. A second check can be taken by the other specialist. A team should be there, and a proper counseling should be done for the patient. Surgical excision remains the standard for the diagnosis in case of persistent, dubious, or indeterminate cytology. So thanks, friends. We need not to worry too much with every nodule. Every nodule is not a cancer. Thank you so much. Bye bye. Good night.